This is Stanford Engineering's The Future of Everything, and I'm your host, Russ Altman. Today, Professor Mike Snyder from Stanford University will tell us how he uses wearables and constant monitoring of his physiology to detect small changes that may indicate disease, often before any symptoms are obvious to him or his doctors. It's the future of big, personalized data. You know, there are many things we can measure about human physiology. When we go to the doctor, they can measure our blood, our urine, even our poop for disease. That happens, once a year, once every couple of years. We can wear smartwatches that measure our heart rate or our oxygen, and we may or may not pay attention to that. But what if we were measuring this stuff constantly, wearables all the time, regular measurement of our blood and other body fluids? What would we be able to learn? Well, Mike Snyder of Stanford University is one of the most measured people in the world. He's collected gigabytes and gigabytes of data about his own physiology over the last several years, and he's started to learn some things. In fact, he's learned enough things that he got 100 other people to do this kind of intense monitoring, and he reported in a paper that at least 50 of them, about half, found major medical problems using one or other of these technologies to monitor both their baseline and then changes. So, Mike, you're one of the most measured people in the world. And what I mean by that is you've made the most measurements of yourself over the last few years of pretty much anybody. How did this all get started? And what's the scientific kind of goal for making all these measurements, which we'll talk about in a second?
Sure. Well, it started a long time ago. We, believe it or not, our claim to fame is studying biological systems by collecting big data around them. People used to study genes one at a time. And our shtick was, let's go in and study all the genes involved in a process, and then proteins and RNA. And then basically, when we always wanted to apply it to medicine, and then I moved to Stanford, as you probably know, 13 years ago. And it was a great opportunity to do that. We could just start taking some of these approaches we invented and things like that and start getting big data around people. And of course, I thought I'd start with myself.
Yeah, I guess the consent issues there are more straightforward. You just have to agree.
Much.
So let's just, for people who haven't. So this is often called the quantified person, or the measured person. So give us a sense, first of all, for just what's the basic data that you collect. Where does it come from? I know it involves some wearables, but also some biological samples. So just take us through the kind of data that you collect, and then we'll go through why and what are we learning.
Yeah, sure. It started with the omics data. And what I mean by that is, for those who don't know, it's like sequencing your genome. That was brand new when we started this. Just a few genomes have been sequenced. We just sequenced mine as part of this. But we do much, much deeper than that. We always thought genomics is a part of the picture. In fact, I'm going to back up a little bit and just say, we envision, health as a 1,000-piece jigsaw puzzle. And the way they measure it today is by collecting about 5 of those pieces. They're key pieces, mind you, don't get me wrong. But it's not like getting 800 pieces where you have a much clearer picture. And so what we're trying to do is, by collecting this data, get that clearer picture. So it started with these omics data, meaning your genome, as I said, then all these molecular measurements out of blood. So we'll take common blood draw like you normally do in a doctor's office, but we'll just dive deeper on it. We'll measure all your RNA as much as we can, your proteins, your metabolites, your lipids. And then, to be honest, we measure your poop, your microbiome. Some of you know that's super important for your health. And then later, as actually the fitness trackers came out, we said, well, these are pretty good health monitors. Let's try those too. And we put them on the Apple Watch that exists, and son of a gun, those were pretty powerful for measuring health. So at the end of the day, we're doing deep clinical testing, these omics I mentioned, which is all the proteins, lipids, and such, and then wearables, and we do questionnaires, stress questionnaires, things like that. And then we do some advanced tests as well.
So tell me a little bit about the wearables, because I've been at a meeting with you a couple of times where you come in with a lot of stuff hanging on your, if you don't mind me saying, hanging off your body. So go through some of the details of what you're actually measuring.
Yeah, sure. So I am pretty wired up. So here are my 4 smartwatches. I think you can see
4 smartwatches for those who are listening. Yes.
Yeah. So it's it's a Garmin, a Fitbit, an Apple, and then of course my company. We can talk about that if you like, which is a bit higher resolution and lets us measure a little bit more. And so we have that. I have a continuous glucose. So they'll measure, by the way, heart rate variability. They're all pretty good for that. But then skin temperature, some do, some don't. Some are accurate, some aren't. Blood oxygen and blood pressure, I would argue none are perfectly accurate, but the deltas are good. And that's what's key to this whole business.
When you say delta, you mean the changes over time might be more accurate than the absolute measurements.
Correct. Yeah. Thanks for clarifying. Yeah. Absolutely. So, and that's true. We can see changes even with I almost said crappy, but a crappy device.
It's okay. This is YouTube and radio and podcasting.
You can pick up these shifts pretty easily. And that's the thing about continuous monitors. That's why we like wearables. They track you 24/7, 365 days a year, as long as you keep them charged. And they're just perfect for picking up these shifts. And I mean, we can get into this if you like, but it's how I first discovered my Lyme disease was because my blood oxygen dropped and my heart rate went up. With the latter, I detected with a smartwatch, and the former was something called a pulse ox.
Okay, well, since you mention it, let's go right into that because it sounds like a great example. So, but before that, the reason you have 4 is because you want to make sure that the data is good. I just want to make sure we understand what the reason for 4 is. Some of those are redundant measurements, but it gives you better accuracy when you can average them or stuff like that.
Well, it's more that they're different resolutions. We're trying to figure out what is the optimal resolution. And, the battery drain is a bit of an issue. So you want to get the optimal resolution without draining battery, because if you drain it fast, people miss data, which isn't so good either. Okay. So there is that aspect, but they also measure different things. Some do measure skin temperature, some don't. The blood pressure, very few measure, and blood oxygen, same thing. So they're measuring different things and at different sensitivities. And so at the end of the day, we'll get to this too, but I got Lyme and I had all devices on. We haven't figured it out yet, but I'll figure out which one's going to be most sensitive.
Okay, so let's talk a little bit about Lyme disease. For people, if people who don't think about Lyme disease, it's actually a very difficult diagnosis to make for physicians because it's a tick-borne illness. So people go out into the country, they take a hike, a little innocuous tick, or seemingly innocuous, affixes to their legs, and if it's on there long enough and it takes a meal of blood basically from you, then it can transmit this Lyme disease bacteria, which has very insidious symptoms. There is a rash, but then all kinds of things can happen over months and years, and very often are missed by physicians. So tell me what happened in this case of this Lyme disease, discovery.
Yes. Well, my case is pretty easy to pin down. I spent one day helping my brother put up fences in rural Massachusetts where 55% of ticks are Lyme infested.
Yes.
And 2 weeks later, I'm flying to Norway, and I measure myself all the time, as you can tell, including my blood oxygen. And your blood oxygen normally drops on flights. This is actually not very well known. It's known to pilots, but very few other people, including flight attendants. And it's why you get tired on airlines, by the way. Your blood oxygen drops and you get tired. So anyway, my blood oxygen dropped abnormally low. I mean, much, much lower. It was 90 median value instead of 96 for that kind of jet.
Okay.
And my heart rate went up, which I saw on my smartwatch. I later learned my skin temperature from my smartwatch also went up, but I didn't notice that at the time. That was more subtle. And when I landed, it didn't come back to normal. And so it was all pre-symptomatically, no symptoms. I had no bullseye prior to this.
Bullseye is the name of the rash that they have for Lyme.
Yeah, from Lyme. That's what a lot of people get. Not everyone, and I didn't see it anyway. And so in the end, I did get a fever off and on. I knew something was up. Because of the timing, it was 2 weeks later. I did go to a physician in Norway. I warned him it might be Lyme. He draws blood, sees my immune cells. Yeah, he sees my immune cells are up, says, Mike, you got a bacterial infection. You should take penicillin. And of course, my response was, no, I should have doxycycline. It got a little tense in there for a few moments there. He did give in, but he was very reluctant. My wife was my witness. She speaks Norwegian, so that's why I brought her along.
Gotcha.
Anyway, he did speak English, so it wasn't a problem in the end. But anyway, so he did give me doxycycline. I was going to go above the Arctic Circle, and I did not want to be sick. So I took it. It cleared it up right away. You do take it 2 weeks. And when I got back, I got tested. And sure enough, I was Lyme positive, something called an antibody test. I had the antibodies, but I even had some antigens left, the proteins that are left over from the Lyme. And it's a well-controlled experiment. It just so happens, not randomly, but I gave blood before I left 3 days, and I was negative. So I had actually acquired, it became what's called seropositive during that time.
So this is a really great story, because this is I'm imagining this is the vision of the future that you have, is that there's a constant monitoring, that you can pick up subtle differences that might not have been appreciated before without these measurements. And then even if you didn't know about Lyme disease, you showed up to a doctor who, at least after a couple of tries, probably would have figured out what's going on, even if you hadn't given him the big clue. Did you remember a tick at all?
Well, I did have a tick that had not embedded because I checked myself when I came back from this fence putting up episode. Right. And so I don't know that was the culprit. It's unlikely to be. So maybe it was a hidden one. I don't have much hair, but maybe it was somehow buried in there. Right. Who knows? And I'm not sure he would have figured it out. To be honest, you're only there for a very short period. He made he didn't know it was Lyme. He said, all right.
It's probably not very common in Norway.
Yeah, it's not unheard of, but it's not super common. I warned him ahead of time, though, because of the timing. The 2 weeks, I said, look, this could be Lyme, just to give you a heads up. So when I was in there, he was primed, but he still wasn't ready to go that way. So anyway, I'm not sure it would have come out that way. So I do think this is the future. I think, Right. You've heard me rail on medicine before, perhaps, but I think physicians, and there's nothing ill about it. It's just they only have 15 minutes to spend with you, and you have a lot more time to spend with yourself thinking about these things, and so you do have to take your diagnosis into your own hand to some extent.
So good. So let me ask you about that. Two questions. First of all, is one of the things that you're measuring when you check your blood on a regular basis, would you have discovered the Lyme antibodies through the normal course of this research, where you're taking blood samples all the time and doing these measurements? Or is that not one of the things that you routinely check?
It's not one of the things we routinely check. Now, we do check something called CRP, C-reactive protein, which is a sign of infection. Could be viral, could be bacterial, could be other things. And we do check things, but we don't normally check routinely for Lyme. So but I actually think wearables are going to be the way of the future. Just to continue the story further, we had 2 years of data on me, and I went back and looked at the data, and there were 4 times I was ill as measured by this protein called CRP. One was the Lyme time, 2 were viral infections, and there was a 4th time asymptomatic, but it had just as high of this protein, this measurement as the other times, suggesting I had been ill. And every single time my smartwatch showed I had a high resting heart rate and high skin temperature. Every single time. And it was retrospectively, but every single time we could see it went up before symptoms appeared, because I recorded when the symptoms appeared. So basically that gave us impetus to say, hey, we can detect when you're ill before you know it with a smartwatch. And so we wrote an algorithm. We called it Change of Heart. We thought that was kind of cute. And then we basically showed it worked on me, and it worked on 3 other people, one of whom got sick twice. Every single time before they recorded symptoms, this resting heart rate went up. And so we think it's a very, very sensitive measure. And this was all published in 2017. And then, we kept perfecting the algorithm. By the way, it didn't work well for skin temperature, because I don't think everyone keeps their watch tight on the wrist. It works for me, but it doesn't work for some others. So we basically were improving the algorithms, building a cloud-based infrastructure, and then along comes COVID.
Well, yes. So about that, what is the infrastructure you have for monitoring? You get a lot of data, and it sounds like you're very interested in this. This is your life. This is your research. So you're sitting on the plane looking at your oxygen and looking at your heart rate. But I'm imagining that what's the vision for the future about how involved an individual would have to be in monitoring this data versus having AI or some other software do all the work, so that you can just live your life and not worry about it? Because right now it sounds like you're very involved in watching all of this data.
Oh, yeah, I'm a geek, and there's a few other people like me out there, but the average person doesn't want to do all this stuff. So where it's going to go, I think, is that it's like your car. Your car has a ton of sensors on it. A race car has 400 sensors on it, and they don't have 400 dashes, dials on the screen. They distill the data back, and just like your car has a few gauges, gas, a check engine light, it's called, the speedometer.
Yeah, that's the one we all fear. Check engine that's the bad one.
So anyway, we have have that, and that
Check
distills
body.
information.
We're going to have a check body light.
You got it, and that's exactly right. I think that's what we're going to be seeing in the future, and that's how it should run. And so we built, believe it or not, that system for COVID now, and that's where it's going to go with this, that we can actually detect COVID in advance of symptoms. And retrospectively, it's 4 days, but we built this real-time alerting system, meaning we'll follow your background. This is how it's going to be. Follow a person's baseline and look for that jump up, a signal that's abnormal. And resting heart rate turns out to be way, way better than, say, temperature that we're measuring now. Like COVID, half the people don't get a fever.
Yep.
But they all have their heart rate jump up.
Can you distinguish it from other viruses?
No, not yet. I hope we might be able to, but I honestly don't know. And it's not just specific for viruses. Our alerting system, it's a general stressor, meaning workplace stress is the number one trigger of we call them red alerts. It'll give you a red alert if you have one of these abnormal signals. But right now you have to click on it. Soon we'll tell you automatically. You don't have to click. But right now you click on it once a day and you'll see if you got a red day or a green day. Red days could be stress. It also turns out if you run a marathon, you some people may know this, your heart rate will be up for a few days after that.
Yes.
That's a red alert. Things like that. So some of it's very easy to contextualize. Some of it, if you're just sitting around and you're not really stressed and somehow that you're getting a red alert, something's up. You're either mentally or physically stressed, potentially from a virus. So
this is The Future of Everything with Russ Altman. More next with Mike Snyder. Welcome back to The Future of Everything. I'm Russ Altman, and I'm speaking with Mike Snyder from Stanford University. In the last segment, Mike told us about how he's doing constant monitoring with wearables and with tests of his physiology. In this segment, he'll tell us about an exciting series of experiments he did with COVID, on himself, of course, and he'll also tell us about how he can make measurements from a single drop of blood. That may sound familiar. Mike is aware of that. He'll tell us why this is different. Welcome back to The Future of Everything. I'm your host, Russ Altman, and I'm speaking with Mike Snyder from Stanford University. In the last segment, we talked about this exciting idea of having all these wearables, all of these blood and other bodily fluid samples to do a real full court press on understanding the state of your physiology, really day to day, hour to hour. So, Mike, you were telling us about COVID, and I don't think we finished that story. I think you had a personal experience with COVID. So tell me, how did all of these sensors and stuff perform in the setting of COVID?
Yeah, so we have this real-time detection system that we've been using, and people have been using. It even picks up asymptomatic cases, by the way.
Wow.
I do want to warn you, it only works 80% of the time. We have more perfection to do. But it did work for me personally, which is I woke up one morning a little bit congested. Is it allergies? Am I getting something? I honestly didn't know. I still felt pretty good. So I did an antigen test, and it came out negative. So I looked at my smartwatch alerting system, and it came out positive. It said red alert. And I was due to fly to New York City that day. So what did I do? I got on the plane because I listened to my antigen test and not my smartwatch. And once you know it, the next morning, in order to go to the meeting, you have to do a COVID test. And sure enough, I'm bright positive. And so I had to spend a whole week in New York City stuck in a little hotel room, all because I listened to this antigen test. And so the bottom line is that we think it's more sensitive. It's not as specific, meaning I didn't know I had COVID. That's a drawback. But it is more sensitive than an antigen test. And I think it works because, again, we're following you 24/7.
Yeah.
And 2 beats per minute is enough to get a red alert. You can easily see that.
And the other great point is that even if it's not COVID, it's not clear that the other people want to be in a meeting with you, even if you have a common cold, right? So I could see that. And one quick thing before we go on to the next topic, you showed us that you were actually literally wearing 4 watches right now.
I am. Yep. Here they are.
Is anybody working on the single watch solution? Because obviously in the real world, nobody's going to wear 4 watches.
Yeah, no, they're all converging too, right? They're all starting to measure more, get higher and higher resolution. From our standpoint as a researcher, it's hard to get the data from some of these companies. And so it's one of the reasons we founded our own watch. But there will be one, maybe they'll all converge on the same sort of high resolution measuring SpO2, something called galvanic stress response.
Yes. Is there a move to get open standards so that they could all kind of use the same interface to represent the data in the same way? This is asking a lot for competing companies to cooperate, but sometimes they do this. Is there any move in that direction?
Well, I think so. They're all using kind of common devices, PPGs and things like this. So I don't think it's that hard to convert them into common standards, to be honest. And they have a common sharing system like HealthKit, things like that, for collecting all the data. So I think we'll get there. Which one will win? I'm not going to predict. It's hard to say.
Okay. So I want to do a switch to recently there was a report out of your lab of sampling a drop of blood and getting a whole bunch of useful information. And forgive me, Mike, but I've heard this story before. It's been in the news. Tell me what you guys have done. And is this the same as we've heard about, like in the context of Theranos, or is this very different?
Well, the concept's the same, but the execution's different.
Yes.
Yeah, so obviously our stick is collecting a lot of data from blood, and we've been thinking about this. We spent 6 years working on this. This is not a fly-by-night operation, trying to figure out what is the right collection method. Getting very fixed volumes turns out to be important, and finding things where the molecules in your blood will be stable and making sure they don't degrade. Because in our system, what you do is you do a little prick. Yeah. So I guess to rewind here, you do a little prick. You take a tiny little drop.
I'm surprised that you're not wearing a black turtleneck.
Well,
Forgive
that's
me.
not quite my
Forgive me.
style. I probably wear the same color pants, but everything else isn't quite like that.
Okay.
So anyway,
Please, I interrupted. I apologize.
No worries. And so you take, for those of you who are geeks, 10 microliters of blood, sometimes 20, it depends, from your either fingertip, or these days we do it from your shoulder. And the nice thing is you collect this at home, so you don't have to go to a doctor's office. So we want to transform the whole system, meaning no more going to a doctor where there's a lot of sick people, giving a lot of blood, for which they use a tiny little bit to measure things, and then give you a report back on something that they compare to everybody else, which isn't the way to do this stuff. So what we're trying to do is collect these little droplets at home. When you're in a native environment, you literally mail it in, FedEx it in, and we've set it up in a way that we think most things are pretty stable. And then we do our deep data dive, where we measure in the lab all your metabolites, lipids, some key molecules called cytokines and proteins, things like that. And then we can actually develop a report and send it back. So in the lab, we're measuring about 2,200 things.
Wow.
So 2,200 analytes, and many of them are very, very key, including some like glucose control molecules, are called insulin, something called incretin. And this is a big deal because we think we can dissect diabetes into its subtypes with this kind of measurement system.
So I'm going to guess that among those 2,000 things, some of them are normally clinically measured things that we normally get with the blood samples that we give. But it must be that many of the things you're measuring are kind of new to measure in a clinical situation. So how do you get like clinical validation that these are useful? Do you go through the FDA and get kind of approvals, or how does it work when you're measuring new things that nobody has ever measured before?
Yeah, great question. So this is a research project as we run it in the lab, but it does have a lot of high-value molecules. Things like cortisol, you probably have heard about. That's an indicator of stress. These molecules called cytokines, which are stimulators of the immune system, and some of these glucose related molecules, control molecules. Some of them are normally measured in the clinic, but some aren't, that could be pretty valuable. So we are seeing a lot of what other people do. By the way, we're not doing everything. Like we don't get glucose or LDL, which is pretty important because it kind of swamps out the system. So you do get them by your standard measures, but we'll see a lot more. And we think that gives a clearer picture. And a lot of these molecules we're seeing, believe it or not, are up on the FDA website. Some of these are molecules involved in depression, or some of your amino acids and things like that are pretty important to know about, actually. So we think what it'll do, they're not FDA approved, but I think they will fit into medicine at some point. They'll have to go through the usual rigorous, vetting and such. And then I think they will, but right now they can be done under research, and they can give you sort of a wellness indicator. We've actually spun off companies to do this sort of stuff. One's called YOLO, that's actually measuring 650 analytes, and another's called Rhythm, that's actually measuring key analytes, we think, for long COVID. So we're trying to get useful information out of this that the medical system right now doesn't capture. And it's the same concept, getting a much, much clearer picture of your health by measuring more things.
How is the accuracy of those measurements compared to the old-fashioned kind of gold standard ways of measuring them?
Yeah, it's pretty good. Some analytes aren't as good, meaning they're because they'll break down or what have you, but many of them are just as good. We do it with a technique called mass spectrometry, which is different from immunoassays, and that has pretty good control, meaning you can see things with a pretty reproducible a measurement. So,
yes.
So it's pretty good. Now, a lot of the things people measure, like we mentioned this protein before, CRP, that thing jumps up 100-fold when you're ill. So you don't have to worry about being 15% off if that's the case.
I see. So the tolerances and how much precision you need is actually different for all 2,000 of these. And so some measurements that if they're a little noisy, it's acceptable, and other ones you really have to nail exactly right, I guess.
Right. But I think the key to all of this, and this is a big concept for us, it's not just collecting big data, it's the longitudinal aspect.
Yes.
So being able to see these shifts was key for my Lyme, it was key for COVID, it's key for everything. Know your baseline so you see the shifts. We don't do that enough in medicine. Even when we collect the data, nobody goes back to look at the old points. And this came out from one of the people we were measuring. He was perfectly normal on one of his liver enzymes, but at the low end, very constant. And then he actually, for one of his visits, he's part of this measuring group we're doing, he jumped up twice as much, but was still in the normal range. Nobody said anything to him. And so he came to me.
For him, it was high. For him, it was very high.
So he came to me and he said, Mike, what's going on here? I'm up double. And I looked at this and said, go get another measurement. It was a week later. So he did. And sure enough, then he shot out of range. So he was on this bad trajectory. And then he actually took, ironically, he changed his diet and actually it solved the problem. I'm not saying that'll happen for everybody, but it did in his case. But it was all about the trajectory. And that's been true, by the way, in one of the other. So we've spun off a medical version. Sorry if this sounds like a plug on this, but a medical version that our company QBio does that actually does whole body MRI, which medicine doesn't terribly like, as well as sort of a medically relevant version of what we're trying to do. And same thing, we've caught people with these longitudinal measurements that are shifting away, and we call it early pancreatic cancer by longitudinal measurements. It's almost never found, but we could see it because of this increased.
Fascinating. So just as I guess the final question, because this is very exciting and it looks like it's coming to all of us soon. You talked about the importance because of battery and stuff of getting the right sampling frequency for your wearables. What's the right sampling frequency for these microfluidic micro samples that you're doing? Is this the kind of thing you imagine doing every day, every week, every month? It sounds like we really need to learn the rate at which these molecules change in order to catch the things we want to catch.
Yeah, so the answer is I don't know, but we're starting quarterly, which is not a bad way because if cancer happens, it can go pretty quickly.
Right.
So that seemed like a reasonable place to start. But I also think it's going to depend on what you're at risk for. If you're at risk for diabetes and some of these metabolic things, maybe you do want to get them measured a lot more frequently than if you're at risk for other things. You'd probably want to get those measured more frequently, like inflammatory diseases, maybe get the cytokines and some of these other inflammatory markers measured more often. So I think it's going to come down to your particular situation. But I could see a world where in the future, the Mike Snyder world is that you have a mirror set up first thing in the morning, you're wearing your wearables, it by Bluetooth over into your mirrors and tells you, green lights on all these things, and maybe some yellow lights or red lights on a few things that you need to work on or keep an eye on. And then you have a finger prick sampling, either that gives you instant readback for a few analytes, but for other things you'll mail in and get back a report. Right. And that won't change, it won't make doctors go away, don't get me wrong, it's only going to help. Yeah. Physicians, if they have this background data, to be able to give you better diagnosis of what's going on with your health and if something's popping up.
Thanks to Mike Snyder. That was the future of big personalized data. You've been listening to The Future of Everything with Russ Altman. You can follow me at RB Altman, and you can follow Stanford Engineering at Stanford ENG.